Chairperson, Dr. Mahalakshmi Sarman. So she is the founder, director, chairperson of ARC chain of Fertility Hospital and Research Center and Abhijay Specialty Hospitals. She is a consultant on obstetrics and gynec with more than 20 years of experience in obs and gynec, laparoscopics and infertility. She has successfully treated more than 20,000 couples across the world, more than 6,000 deliveries and 8,000 laparoscopics been conducted. She is an expert with multidisciplinary skills and continues to give excellent results in advanced fertility treatments, high-risk pregnancies, laparoscopic and therapeutic hysteroscopies. She is an active member of ASRM, SRI, ISAR, IFS and IMA. Our vision of continuing improving and developing advanced healthcare delivery system be to establish and practice scientific and evidence-based treatments in various medical specialties, provide quality healthcare to all economic groups, and we have our mission called as the Kolande Illai Ini Kavalai Illai. So what is the ARC's expansion in the next year? We are coming up with various branches in Bangladesh, that is in Dhaka, and Sri Lanka. We already have a Sri Lanka Colombo International branch. We are the only center which has an international branch which is in Colombo, and we are coming up much more information centers and collaborations with other hospitals in various parts of Bangladesh, Malaysia, Singapore, Canada and the Middle East. I would like to call upon Ms. Pravalika to introduce the speakers and also carry the for the sessions. Ms. Pravalika is a student of embryology. She is with us in ARC Nellore. We also provide academics, FRM course and clinical embryology course, both affiliated by Savita Medical University. So she is a student of ARC pursuing her embryology, clinical embryology in ARC Nellore.
Today's speaker is about Dr. B. Divyashree, MBBS, MS, JEE in Medical College, Davangere, and she also studied in MS Obstetrics in JSS Medical College, Mysore. FMAS World Laparoscopic Hospital, Delhi Fellowship in Reproductive Medicine from the Kraft Center and Research Fertility Center. Consultant in Zonal Head in ARC Fertility Hospital and Research Center. And her topic is about assistance in ART in completing family.
Thank everyone for attending this CME and Doctors Meet. I'll be talking about assistance of ART in completing the family. So I'll be discussing about some cases which we have done at Nellore ARC, in what way ART has helped them achieve their dream. So as we all know, infertility in India has become the new epidemic. WHO has estimated the prevalence of infertility in India to be between 3.9 to 16.8%. So according to a recent report by WHO, 1 in every 4 couples in developing countries is affected by infertility. So for many couples, the use of the ART is the only way to achieve pregnancy and realize the dreams of parenthood. So the use of ART has been on the rise, as there are more than 7 million children who have conceived through ART. So the fertility rate of women in India has drastically fallen down in the last 15 years. From 1950, if we see till 2010, there is a drastic fall in the fertility rate of women in India. So then what are the ARTs and how will they help the couple who are planning for pregnancy? So ARTs are called as artificial reproductive technologies, and they refer to the medical technique and procedures which help people achieve pregnancy when natural conception is not feasible. So as we all know, we follow different methods and help an infertile couple plan their pregnancy. So starting with some difficult cases, So major problem what we are facing or what I am seeing in my day-to-day practice is the poor responders. So most of the women who are coming with a very low AMH. So but that doesn't mean they can't have their own biological baby. So we have categorizations for poor responders into 4 groups. Those categorization is given by Poseidon, and it has 4 groups in that. Group 1 includes the young patients who are less than 35, but still their adequate reserve is okay only. But that means their AFC are more than 5 and AMH is more than 1.2, but they have an unexpected poor or an suboptimal response to our stimulations. Poseidon group 2, similar category, but the patient's age is more than 35. Poseidon group 3, younger patients with poor ovarian reserve. That means women with less than 35 years who are having AFC less than 5 and AMH less than 1.2. And Poseidon group 4 includes the older patients more than 35 with poor ovarian reserve. That is AFC less than 5 and AMH less than 1.2. So one such case I am presenting here. One patient, Mrs. X, she is 37-year-old. She came to us. When she came to us, her AMH when we checked it was 0.2 and her day 2 AFC were around 5. Her day 2 AFC were 5. So previous history, going into her previous history, she already tried 6 cycles of IUI, all were negative. There was no any male factor infertility. Her uterus and tubes were looking okay only. So she she wanted her own biological baby, so she underwent ICSI. So we could aspirate 4 oocytes from her. 3 were M2s, and out of that 3 we could get 2 day 5 blasts. So frozen embryo transfer done with HRT protocol, and and her urine pregnancy test positive, and she's an ongoing pregnancy now. So what has helped this patient with 0.2 AMH conceive? So usually what all the people follow is the normal antagonist protocol what we follow, but changing the protocol depending on the patient's AMH, age and AFC could help patient conceive also, because we tried a different protocol, that is modified flare protocol. So going against normal, whichever antagonist we follow for all the patients, we changed it over to a modified flare protocol, and we helped the woman get her self biological baby. So there are different protocols. So usually what we follow for universally is antagonist, that is usually LH surge is prevented by giving antagonist from day 6. So agonist is we are not using much of agonist, but some patients, by selecting the patients, we can help patients with low ovarian reserve also get some embryos of their own. So androgens, like androgens for women undergoing ART. So many of us will be prescribing the DHEA tablets for the women with ovarian reserve. So what is the Cochrane says about this? So totally 17 RCTs were studied regarding this androgens in the patients with poor ovarian reserve. So totally 1496 participants were studied. So pre-treatment with DHEA or testosterone may be associated with improved live births. So even with the patients with poor responders, we can try giving DHEA or testosterone for 2 to 3 cycles before going ahead with stimulation, so that we can have a better success rate. So this is another patient. This is a very young patient, that is just 30 years only, but still her AMH is 0.24 with only 5 total AFC. So we went ahead with the stimulation. We got 1 day 5 embryo which has been transferred through frozen embryo, FET was done, and we got a positive result, and she's an ongoing pregnancy patient now. So this is another patient. She's a very young patient, 26 years. Her but married since 3 years. So in the past 3 years, she had multiple cycles, 2 cycles of IUI which were negative. She underwent laparoscopic ovarian drilling because she was told that she had PCOS and her tubes were patent. So when she came to us, her AMH was 0.65. So we advised her ICSI. We went ahead with ICSI, but to her first ICSI we could aspirate 9 oocytes, but only 1 embryo is obtained because of the very poor oocyte quality. So this is another case of poor responder where the oocyte quality has been completely compromised. So we advised her for embryo pooling. So second ICSI again she underwent, we got 7 M2s, then out of which 1 blast we could make. So both the embryos were transferred for once at embryo transfer, and she got a positive result, and there is a she's an ongoing pregnancy patient. So that means accumulation of oocytes or embryos is a new strategy for managing low responders, because these days when we have a low AMH, advising donor is a very difficult task. Getting a donor is also a very difficult task. So even with the patients with very low ovarian reserve or a poor oocyte quality, we can still give them their own biological babies by following little changes in our treatment modalities. Next, coming to the patients with endometriosis and infertility, as we all know, the monthly fecundity rate is reduced to 2 to 10% in case of endometriosis as compared to a normal couple in which it is 20%. Even minimal endometriosis may present with severe infertility. So infertile women are 6 to 8 times more likely to have endometriosis than fertile women. So this is a case of Mrs. X, who is 26 years old, married since 6 years. Her AMH is 1.4 and her day to AFC were 11. She doesn't have any medical comorbidities. She underwent a surgery in 2022, that is a diagnostic lab, for which she underwent chocolate cyst excision with ovarian drilling, and she also was said that she had left tube hydrosalpinx but right tube was patent. So adhesions were present, and it was given that it was a deep infiltrating endometriosis. So ultrasound, when she came to us, it was showing also posterior wall adenomyosis, and left ovary had 2 big chocolate cysts, each of 3.5 centimeters. Male partner, the semen analysis was normospermia. So we advised her for ICSI. So totally we could get 8 oocytes, out of which 5 were mature oocytes, of which ICSI was done, and we could get 3 day 5 embryos. First attempt only, FET done by giving a leuprolide HRT protocol. By giving leuprolide for past 2 to 3 cycles followed by HRT protocol, we could give her a positive beta HCG report. This is another patient with adenomyosis. She is a patient of 31-year-old, married since her AMH is 1.7 and her day to AFC were around 12 to 13. Ultrasound was showing it was a very bulky uterus, so it was almost 10 to 12 weeks uterus. Her male partner semen analysis was normal. So in spite of having such bulky globular adenomyotic uterus also, following few changes, giving her leuprolide for 2 to 3 cycles followed by frozen embryo transfer, we could give her a positive result. So should we always excise the chocolate cyst or not? How is that affecting the ovarian reserve? So the impact of excision of ovarian endometrioma on ovarian reserve, this is a systemic review and meta-analysis. Our primary aim is to see the change in mean serum AMH after surgery. So total 237 patients and 8 studies were included in this analysis. There was a statistically significant post-operative fall of AMH. So we can conclude that ovarian cystectomy for endometrioma seemed to cause significant damage to the ovarian reserve with up to 40% fall in the serum AMH concentrations. So if an infertile couple with a chocolate cyst, if you are planning for chocolate cyst excision, there would be a drastic fall in AMH in her future. So management of endometriosis in women requiring IVF, to touch or not to touch. Laparoscopic surgical removal of ovarian endometriotic cysts prior to IVF does not offer any additional benefit in terms of fertility outcomes. We recommend proceeding directly to IVF to reduce the time to pregnancy and to avoid potential surgical complications and to limit the patient costs. Proposed indications for resection of a suspected endometrioma prior to ART, rapid growth or when malignancy cannot be ruled out, or painful symptoms that can be attributed. Long-term pituitary downregulation before IVF for women with endometriosis. So the administration of agonist for a period of at least 3 to 6 months prior to IVF or ICSI in women with endometriosis increases the odds of clinical pregnancy rate by 4-fold. This is a patient with thin endometrium. So Mrs. X of 34 years, and she is married since 11 years, secondary infertility. Both were 2 miscarriages and the last conception was around 8 years back. So previously she underwent one hysteroscopy where it was told it was normal, and endometrial biopsy was also taken, it was normal. But with the maximum dose of estradiol valate what we have given, the maximum endometrial thickness what we could achieve is 5 mm. So the patient was suggested uterine PRP. So uterine PRP has been done, and followed by next month we went ahead with a frozen embryo transfer. So that cycle where we went with frozen embryo transfer, her endometrial thickness was around 5.5 mm, but the vascularity was around grade 2 to 3. So along with that uterine PRP, we also gave her granulocyte colony stimulating factor also, 2 to 3 doses of injections during the endometrial preparation. So with this all drugs, she could have a, after embryo transfer, we could give her a beta HCG positive result. So what is GCSF? It is a glycoprotein and a cytokine produced by many tissues and cells. So in patients with thin endometrium, endometrial cell regeneration, it helps in endometrial cell regeneration by mobilizing the stem cells to the endometrial injury location. So endometrial vascular remodeling happens when we give this GCSF, so that helps in better implantation. So the effect of GCSF on infertile women undergoing IVF treatment, it is a meta-analysis. 6 studies and totally 607 patients have been included in the study. The use of GCSF was ineffective in increasing the endometrial thickness among infertile women undergoing IVF. But however, compared with the placebo or no treatment, the implantation rate, biochemical pregnancy rate and clinical pregnancy rates were significantly higher in patients with a thin endometrium or repeated IVF failures using GCSF. Uterine infusion of GCSF is a novel proposal for immune therapy in patients with thin endometrium or cases of repeated IVF failures, and it might not be simply for increased endometrial thickness. As said, GCSF usage might not increase the endometrial thickness, but for sure it has an effect on implantation by increasing the local growth factors in the endometrium. But larger studies are still required to have a definite idea for the same. Coming to autologous PRP we all might be knowing because this has been used in various fields nowadays. So how does PRP help in thin endometrium patients? So PRP has many growth factors in it, that is like platelet derived growth factor, fibroblast growth factor, epithelial growth factor, vascular endothelial growth factor and transforming growth factors. So by injecting this PRP into the endometrium, we can help the patients with thin endometrium conceive. So this is an article, autologous platelet rich plasma promotes endometrial growth and improves pregnancy outcome during IVF. 5 women who had cancelled cycles due to refractory thin endometrium. In new cycle, we gave 12 mg per day E2 and on 10th day PRP was obtained and 2 centrifugations of 15 ml peripheral blood was done and 1 ml PRP immediately given into the cavity. We can see the results. So we have there was many ongoing pregnancies in the patients with refractory thin endometrium. So thin endometrium is not a no for IVF. Coming to unexplained infertility. So this is a patient, Mrs. X, of 29 years, married since 5 years with primary infertility. Her cycles are regular. There is no other medical or surgical history. She underwent ovulation induction and timed intercourse for 5 cycles, and IUI was run thrice and all were negatives. And her AMH was 4.2 and her day 2 AFC were 18. And male semen analysis was also normal without any, male also didn't have any comorbidities. So after trying natural and IUI, she approached us and so we suggested ICSI for us. Totally, we could aspirate 17 oocytes and out of that 13 were mature oocytes and we could give 5 blasts, day 5 blasts for her. In first attempt only with HRT protocol, we could give her a positive pregnancy. What does the evidence say? So when to shift over to IVF in a patient with unexplained infertility? So this is a fast trial, fast track and standard treatment trial given in Fertile Sterile 2022. So to determine the value of gonadotropin IUI therapy for IUI women aged, this is a trial where the women aged between 21 to 39 years are taken. Totally 503 couples diagnosed with standard definition of unexplained infertility were included in the study. So the primary outcome was the time it took to establish a pregnancy that led to a live birth and cost effectiveness. So the conventional arm, first they followed 3 cycles of clomiphene citrate with IUI, then 3 cycles of gonadotropin IUI, then followed by IVF. In the accelerated arm, after 3 cycles of clomiphene citrate IUI failure, they immediately shift over to the IVF. So what is the conclusion of this fast trial? So gonadotropin IUI treatment was of no added value in the case of failed oral superovulation. Accelerated approach to IVF that starts with clomiphene citrate IUI but eliminates gonadotropin IUI results in a shorter time to pregnancy with fewer treatment cycles at a suggested cost saving. So after 3 cycles of failed IUI, it's better to shift over to IVF to reduce the time to pregnancy and to make it more cost effective. This is another trial where this is called a 4th trial where the women aged more than 38 years are included, same in unexplained infertility only. So this is an RCT. The primary endpoint is the clinical pregnancy rate after 2 cycles of treatment. So the couples with more than 6 months of unexplained infertility. Female partner age is between 38 to 42 years. What is the hypothesis? Immediate IVF is more effective treatment strategy for reproductive older women who demonstrate a reasonable chance for success than treatments that begin with superovulation. So the conclusion is immediate IVF in a woman with more than 38 years is the most effective treatment for couples with unexplained infertility when the age of the female partner is at the end of the reproductive years. Immediate IVF demonstrates reasonable chances of success. Immediate IVF shows superior pregnancy rates and fewer cycles of treatment. Average time to conception is somewhere between 12 to 8 months, indicating that those who conceived in IVF arm did so on an average of 3.5 months faster. For couples who do not want immediate IVF, this trial support the use of clomiphene citrate IUI rather than gonadotropin IUI, given the comparable success rates, efficacy to gonadotropin IUI, and easy and less costly for the patients. So a couple with an unexplained infertility, we always prefer going with oral agents with IUI for 2 to 3 cycles, and if that doesn't work out, better to shift over to IVF to get to decrease the time to pregnancy. So this is a patient. Next, coming to the fibroids, Miss 6 of 40 years. This is our patient who has been married for 10 years and her cycles are regular with primary infertility. So her AMH is also on the lower side, 0.4. Her day 2 AFC were 4. She doesn't have any medical or surgical history. She doesn't have any other medical history. So her HSG report showed she had a right tubal block, but the cavity looked normal. Previously, she underwent 5 times IUI, all of were negative. Her ultrasound was showing subserosal fibroids of 1.3 into 1.2 centimeters and one more subserosal fibroid of 1.6 into 1.9, and she also had an intramural fibroid of 1.5 centimeters, which is less than 5 mm, more than 5 mm away from the cavity. So when to touch fibroids in an infertile woman? She underwent ICSI with us because her AMH was 0.4. We could aspirate only 1, but to her luck, that 1 was converted into a day 5 blast. Leuprolide HRT protocol was followed and her beta HCG is positive. So when to touch the fibroids? According to study, the type 3 fibroids are the fibroids which are just touching the endometrial cavity. Intramural fibroids that are touching the endometrial cavity exert a negative impact on the rates of implantation, clinical pregnancy and live birth rate in patients undergoing IVF and ICSI, but do not increase the clinical miscarriage rate. The deleterious impact of type 3 fibroids was remarkable in women with type 3 fibroids with total diameter or single diameter more than 2 centimeters. So type 3 fibroid, if single fibroid diameter is more than 2 centimeters or cumulative diameter more than 2 centimeters, then it's better to go ahead with removal. Otherwise, not required. Intramural fibroids above a certain size, that is 4 centimeters, even without cavity distortion, may also negatively influence the fertility. Then the other study concluded that in asymptomatic patients selected for IVF, small fibroids with a diameter less than 5 mm not encroaching the endometrial cavity do not impact the rate of the success of the procedure. So number of fibroids. From a retrospective cohort study, the deleterious effects of fibroids on live birth rates were significant in women with 2 or more fibroids and in women with fibroids more than 3 centimeters in diameter. Distance from the fibroid. Distance of the fibroid from the endometrium. So the fibroids with a distance of less than 5 mm from the endometrium lining might affect the clinical pregnancy rate compared to the fibroids which are more than 5 millimeters away from the endometrial lining. So how, next coming to the polyps. So in a prospective study of 1,000 patients undergoing hysteroscopic evaluation of the uterine cavity prior to IVF, the prevalence of endometrial polyps was found to be 32% even with an asymptomatic patients. Most of the times expected management is followed and a polyp less than 1 centimeter regress spontaneously in the next further cycles, but surgical hysteroscopic polypectomy is the gold standard for the polyp. Next, coming to a patient with recurrent implantation failure. This is a patient of 34 years who used to travel to us from Vijayawada all the time. So she is married since 15 years and she is a patient with primary infertility. She doesn't have any other medical history. Previously, she underwent one diagnostic histro lab where everything looked normal. She almost had 20 cycles of IUI, all of which were negative. Also, 2 cycles of ICSI at an outside hospital. First ICSI done at an outside hospital, FET negative. Second ICSI again at an outside hospital, fresh ET, it was negative, and second was in frozen ET, that was also negative. So third ICSI was done at ARC and we could get 3 day 5 embryos for her, and first FET done in ARC, it was also negative. So we suggested her with endometrial receptivity assay. It was done on P+5. That means we usually take we usually transfer embryos on giving 5 days of sustain followed by 5th day, because most of the times in ARC we do only blastocyst transfer. So that was the day we have taken her biopsy, and the biopsy report came to be non-receptive. That means the implantation window for this woman has been altered. That is the reason for all the negatives she faced throughout her life. So second FET was done according to the endometrial receptivity array, because the first endometrial receptivity test showed that her endometrium is pre-receptive. That means still the implantation window hasn't opened. So go ahead for delay the transfer by 1 more day. So next attempt, when we went for the second FET, she had a single embryo that was done on P+6, giving 6 days of sustain followed by transfer, and we had a positive beta HCG report, and she also delivered a male baby. So what is this personalized embryo transfer? Because this is also called as endometrial receptivity analysis. So depending on the condition of the endometrium, usually 95% of the women usually fall into the receptive category, but very rarely some women's implantation window is altered. So when we get an endometrial receptivity test report as pre-receptive, that is, it is too early. On the next cycle or during the hormone support cycle, the start time of the progesterone until the transfer will be lengthened. If it is receptive, on the next cycle, the same schedule will be followed, and after the hormone support cycle, the blastocyst transfer will be done on the same day. If it is post-receptive, next time whenever we are going ahead and doing the embryo transfer cycle, we transfer the embryo a little earlier. So ERA is a genetic test that evaluates the expression of 248 genes via NGS to evaluate the optimal time to place an embryo into the uterus to promote a successful implantation and pregnancy. There is a small window of time that is optimal, and in approximately 80% of the women, this window is in the expected time. But in 20% of the women, it is little different. So this might help in the patients with this kind of recurrent implantation failure. The endometrial receptivity array for the diagnosis and personalized embryo transfer as a treatment for patients with repeated implantation failure. So what does this study conclude? There is an increased percentage of window of implantation displacement in recurrent implantation failure patients compared with the normal group, leading to the concept of personalized embryo transfer as the therapeutic strategy. Efficacy of when do we need to go for this endometrial receptivity? Usually after 2 failed IVF cycles, we advise this endometrial receptivity array for the women. So for the patients with unexplained recurrent implantation failure, where there is a significance in searching for their personalized window of implantation using this ERA, considering the percentage of those who were non-receptive and the pregnancy rates that resulted from the personalized embryo transfer. By transferring the euploid embryos in the personalized window of implantation, much better pregnancy rates are expected. Next, coming to the male factors, one of the increasing factor is the patients with high DFI. These days we get many patients with the normal semen analysis, but most of the times the results, whether it could be IUA or IUA would be negative, or if they are going for an IVF, the conversion of the number of blastocysts would be negative. That might be because of the very high DFI, DNA fragmentation index, because the sperm, even if it is looking morphologically normal with a normal motility also, the DNA inside the sperm might have been fragmented because of the many factors like lifestyle, sedentary lifestyle, smoking habits, so other comorbid conditions. So in the patients with high DFI, we had a patient who had 2 miscarriages. So one of the cause for miscarriage is high DFI in the sperm. So Mrs. X of 25 years, she's married for 4 years and it is secondary infertility. So first she had a blighted ovum, second it was a missed abortion. So husband has semen analysis was absolutely normal, and for the recurrent pregnancy loss there was no other indication, karyotyping, APLA, everything else looked normal. The semen analysis was teratospermia, and the patients were willing for IVF to decrease the time to pregnancy. So when the semen analysis was looked into, the patient's husband's DFI was high, which might be the cause for the recurrent pregnancy loss. So when we found a high DFI, instead of ICSI, we have gone ahead with a further higher procedure, better sperm selection technique, that is PICSI. In this PICSI is higher to the ICSI, what we do regularly, where it can select a better quality sperm with a lesser DFI. So by selecting the sperm through PICSI, we have done the procedure, and we got 2 day 5 blasts for the couple, which were transferred in the first attempt only. It was positive. Now the patient is 28 weeks pregnant. So other higher sperm selection techniques we have to meet the couples who are facing the problems of asthenospermia, teratospermia, globospermia, different kinds of like where the motility issues are there. To select the best quality sperm, we have the higher techniques like ICSI or IMSI, which we are doing depending on the couple's requirement to give the best results. So this is another patient of 30 years. There is no female factor problem, but the male is azoospermia. Fructose test was negative, which is indicating that it is probably a case of obstructive azoospermia. His male hormone profile was done where FSH and testosterone looked normal, and scrotal Doppler was done, which was also showing a normal study. We aspirated 8 M2s. TISA was done and obtained only very few motile sperms, and ICSI was done, so we could get only one day 5 embryo. That day 5 embryo we transferred for the women, and it is an ongoing pregnancy. Even with the men with an azoospermia can still have their own biological baby by proper evaluation and going for the proper surgical treatments. Different kinds of surgical retrieval of sperms which we are following are TISA, TC, PISA and MESI, and micro TISA, which is the recent most and best technique for retrieving the sperms from the patients with azoospermia. These are all the different cases, whatever I have presented have been done at Nellore ARC, and we are trying still to give our best results. Thank you so much.
Thank you, Dr. Diveshri. It was a real and very interesting and informative topic. And Dr. Diveshri is with the ARC as a senior consultant. She also monitors branches in Hyderabad, Ongole and Tirupati. Next, I would like to call our leader, who's really very energetic, fearless, very down to earth. She manages the administrative operations and the marketing of ARC. Been really tough journey, but she made it very simple. She takes the burden of all the departments and makes us be what we are today. So I would like to call Dr. Mahalakshmi on stage, please.
It's a privilege for me to be here in front of all of you today, and I thank Dr. Zoheb for all his excellent words on me. And I would also like to say that he's heading the marketing for ARC, and he appears very simple, but probably when you start getting to know more about him, you'll know like how good he is at his job and everything. So to say about ARC, 2004 we started this as a single center. It was mainly an OBG center for almost 10 years. So after 10 years, to begin my practice, I was only an OBGYN. And after 10 years, I found that in the practice, the fertility treatments for my patients were not adequate. I used to refer them to several fertility consultants. There were only 4 fertility consultants between 2004 to 2015 in Chennai, or even rather Tamil Nadu, I can say, who were really doing the IVF practice. So I used to refer patients, but always the results used to be negative. And the patients who go to the consultants were trusting me and going to them. So they go there, they end up spending lakhs and lakhs of money. And when they become negative, these consultants, they didn't have even time to explain to them why they were negative. So these patients were again put to get back to me to know why they couldn't succeed in IVF. And it's like every time I have to cut a sorry figure to them to refer them to someone and get a negative result, it becomes like it's my responsibility. So there were only 2 decisions that I could take at that time: either not refer them to anyone, or I train myself to do these procedures. So at that time in 2004 to 2015, not many gynecologists were willing to take up fertility practice. It's only now that everyone wants to do fertility practice. So I completely gave up my OBG practice in 2010, and in 2010 I started going in for my fellowship program and specialization in fertility treatments. Beginning, I thought that I will do the OBG practice as well as the fertility practice. But later on, I understood that it is not very easy to give results. So although Dr. Priya has listed so many cases, doing PRP giving results, doing a PICSI and giving result and so on, it's not very easy to give results in IUI or IVF treatment. Every step in the treatment has to be customized. Every patient needs to have personal care for you to give treatment. And the results are only one. Either you make them pregnant or you don't make them pregnant. So consecutively, if you give negative results, whatever marketing you do, whatever advertisements stand for your brand value, the patient's flow will get low because word of mouth marketing is the first thing that comes. So most of our patients, what we have in our fertility centers are word of mouth marketing. Positive patients, they refer their friends and relatives to us. So it was at that instance I decided that I will give my OBG practice completely and do only fertility practice. So it was like at that time, 2010, even though I did my fellowship program, they really don't teach you in fertility as to what you have to do. Now the fellowship courses and everything have come. But at that time, people never used to want others to know what they were doing, techniques to give results. So it was not very easy. So I had to sit with all my patients' file, break my head to see how I could give results for them. And when I was a beginner, I used to get only negative patients from all the centers. So all the patients who have failed IVF at various big places used to come to me. And it was only these patients I had to show results to begin with. And once I started showing results for patients who failed at multiple places, then automatically my practice grew tremendously. So it was in 2010, I started one center. 2015, it was 2 centers. And today by 2023, in between 2 years during COVID, we didn't expand. Now we are around 35 centers throughout the nation and 1 center in Sri Lanka. So what I did is, like, after I started expanding, my first thing was to find people who were really talented below me. So that is how I have 8 zonal heads. And Dr. Divyashri, I'm proud to say, she's one of the zonal head who takes care of Telangana and Andhra. Other than that, for Tamil Nadu, we have another 5 zonal heads and 2 other zonal heads for the other states outside Tamil Nadu. So they know the techniques properly. They know how to customize the treatment for each and every patient and how to tailor module each and every patient to give the results. So, and only those who are really interested and dedicated in their job were chosen as zonal heads. And all the 8 zonal heads, they are extremely doing well. Each one has got 4 or 5 branches below them. So they look into how the other doctors, they give the counseling, how they decide the treatment for them, and what protocols are being followed, what is the outcome of protocols. See, stimulating a patient is not important, but how much of mature eggs you are able to give, how many embryos are created, what is the quality of the embryo, what is the thaw rate of the embryo, how does it convert for implantation. Everything has to be monitored. So these zonal heads, they do all these things. And I also personally visit most of the centers to make sure that the things are still in place. So this is how ARC, although we expand rapidly, we have our own set SOPs. And it's only with these SOPs we can look into our results being in par with international standards. We have our blastulation rates, which are very high, between 60 to 70%. And our frozen embryo results are between 65 to 70% the least. And at times batch results goes up to 85 to 90% also. And we are really not keen in obstetric practice, only for all the high-risk pregnancies like repeated pregnancy losses and IUDs, all those things, we give the high-risk pregnancy care. Otherwise, we send the patients back to the obstetricians for their antenatal care. And the obstetricians are always welcome to discuss with us as to when they can pull down on the steroids, when to taper the estrogen, when to taper the progesterone, heparin, everything. We will be helping them to taper the luteal phase and to have a safe delivery. So apart from this, if you see in ARC, we have the fellowship courses. We have the fellowship courses for reproductive medicine, which is 1-year course. This is affiliated with Savita University. And we have the MSc embryology course. This is also affiliated with Savita University, and it's a 2-year course. So this is about our training program, and we are now going to start even the fellowship in endoscopies. And apart from the training program and the clinical work, we also do a lot of research works. So we have done our research work in platelet-rich plasma. Now we are doing the studies on stem cells, endometrium, stem cell ovarian regeneration, and stem cells testis. So for ovary, we are doing for those women who have decreased ovarian reserve, and even for menopausal, we are doing a study to see if we can reverse the menopause and have them have new follicles getting up. This is called ovarian regeneration. It's called overgraft. And for the same men who have absent sperms, not due to obstruction, non-obstructive azoospermia, we are also doing a stem cell transfer to see if they can have their own sperms produced newly. So these two, the last two that I said are all still research. We are doing the study, and we are going to present it once the study is done. PRP thin endometrium, our study is already completed. We have already published this in the SRI conference, and our paper has also been accepted by the European conference. The next 2 studies, once we complete 250 participants, the study will be concluded and the results will be published. And the next is we are also doing a new study called HLT, that is LIT, we will say, lymphocyte immunotherapy, on patients who have repeated miscarriages or repeated implantation failures. What we are doing is we are taking the husband's blood, the WBC, lymphocyte is segregated from the husband's blood, and this is injected into the wife. It's injected at the axillary site. Usually we do HLA compatibility test for them. Twice we do, then we give them the HLT therapy. And after 2 HLT therapies, they go for embryo transfer. And after she gets pregnant, we give the 3rd HLT therapy, and this helps them prevent miscarriage. This is for immunological cause of repeated pregnancy losses. So this is the 3rd research study that we are doing. So all these studies are supposed to be completed by 23-24, and once these 3 studies are completed, we'll be publishing these results also. So I'm really happy to recognize all your work here, because I have been in the field of OBG and I know how difficult it is to be an obstetrician. We cannot time anything. Whenever we have an important family function or when we need time for our own personal care for the kids, we have an obstetric patient in labor, we have to give up everything. There were many instances in the first 10 years of my practice. I would have been so well dressed up, ready to go for a function. Just then a labor patient walks. I'll have to send everyone for the function. I'll have to remove my clothing, remove my jewelry, change the whole costume, and then go and sit with the patient. It was heartbreaking most of the time to begin with, but later on, when we see the child being born and when we see the happiness in the family, we are happy to do it. So I know how dedicated you are all working, and I'm happy that today ARC has got an opportunity to recognize all your work, and for sure we would like to be associated with you all, and any doubts or any assistance from our side. And I would also like to tell you that all of you know about the new ART Regulation Act that came up 2021 January. And now that most of our ARC centers have been inspected and we have already got license for majority of our centers. And I'm sure if you want us to help you in any of your licensing work also, our officers would be willing to help you also. Okay, anything else that you would like to check with me? And I thank Zoheb again for all his words. The most important is fearless. So I'm sure most of the obstetricians are fearless, because when we handle labor patients, we cannot be emotionally moved. We cannot be fearing as to what the outcome would be. It's like basically when you're an obstetrician, you get self-molded to face any consequences in life. So I think that way we should all be able to move forward ahead. And I'm sure ARC will be a part in helping your fertility patients also to have their childhood journey. Thank you.
Thank you. To honor some of the doctors who had really dedicated their time and service to serve the women's health. So we call them as icons of women healthcare. That is what the recognition is for. So I'd like to call upon, we are having Lifetime Achievement Award to Senior Gynecologist. I would like to call Dr. Vani Madam on stage, please. Thank you so much, Madam.